Hi, good evening, good morning, good afternoon, wherever you are. I'd like to welcome you to this special broadcast by the International Academy for Clinical Hematology. And this is one of our post-ASH 2021 activities dedicated this time to chronic lymphocytic leukemia. I'm sure you are well aware that CLL, which is, by the way, the most frequent leukemia across the globe, and one would expect the incidence will continue to increase with the aging population. We've seen in CLL some tremendous advances. Historically, we used to use the famous FCR, chloraminofen, chlorambucil, whatever you call it. Then, of course, BTK inhibitors like Ibrutinib paved the way. And very recently, we've seen the amazing data with Ibrutinib, which is now approved in first line, but also in relapse, and showing really a very nice safety profile. And I'm convinced that progress in CLL will continue in the next few years, because you may have seen last week this seminal paper in the journal Nature by Carl's June's team about the long-standing, the long-living CAR T cells in 2 CLL patients. So clearly, CLL is witnessing a true revolution in terms of treatment, but also pathophysiology. And thanks to the new generation BTK inhibitors like Ibrutinib, patients are really enjoying and are able to live long and with good quality of life. So I will not spend a lot of time with this introduction. I'd like to introduce Professor Romain Guieze, who is a full professor of hematology at the University Hospital in Clermont-Ferrand. And beside being a good friend, Romain is really a top expert in this field of CLL, and he has kindly accepted actually to give us a sort of a summary and overview about what was the best of ASH 2021 when it comes to CLL. So Romain, thank you for joining us tonight. I would like to kindly remind all of you that you can send your questions and comments, and we'll have some Q&A after the lecture. So Romain, welcome, and the floor is yours.
Thank you very much. So I'm very pleased to contribute to this International Academy for Clinical Hematology webinar, and I'm happy also to talk about all the novelties we have seen at the last ASH meeting.
Let's go for it.
Hello, I am Romain Guieze, a French CLL investigator from the French CLL group, the PHILO. And it's really a great honor to contribute to this webinar. And I'd like to thank Dr. Moti and the International Academy for Clinical Hematology for inviting me. So I'm going to report on the numerous news related to CLL at the last ASH meeting in December. So here are my disclosures. So as you know, chemoimmunotherapy has been the long-standing option for patients in the frontline setting, except for those presenting alterations of the TP53 gene. A large panel of regimens of different intensity, from FCR to bendamustine rituximab to obinutuzumab chlorambucil, was available for patients according to their age and comorbidities. These already resulted in high response rate and prolonged progression-free survival. Beyond chemoimmunotherapy, targeted agents have emerged as potent strategies. So their benefit has been dramatic for patients with TP53 alterations and also clear for patients in both relapse and frontline setting. This consists of the B-cell receptor signaling inhibitors, such as the BTK inhibitors, and the BCL2 inhibitor venetoclax that acts by displacing the pro-apoptotic protein from BCL2, allowing them to activate the pore-forming protein responsible for the cytochrome C release and the final steps of the mitochondrial apoptosis. So the ASH meeting in 2021 was full of novelties for patients with CLL. And here are the key CLL highlights I'm going to go through. So we first witnessed updates for the BTK inhibitors as frontline approach, and also important data regarding the combination of Ibrutinib and venetoclax, including for patients with TP53 description. New hopes are being developed for patients with relapsing disease. And finally, we will review data supporting the lack of response to COVID vaccine. Over the last 3 years, multiple phase 3 randomized studies have, as you know, demonstrated that frontline treatment with BTK inhibitors, such as Ibrutinib or Acalabrutinib, were superior to chemoimmunotherapy with regards to PFS. So far, these compounds are given in a time-unlimited setting, that is until progressive disease or an acceptable toxicity. This superiority was confirmed after a long follow-up as presented by Dr. Voyak. The Alliance study compared 3 arms, Ibrutinib, rituximab Ibrutinib, and bendamustine rituximab in a population of elderly patients. After an extended follow-up of 55 months, 4-year PFS was 75% in Ibrutinib-containing arms and only 47% in the PR arm. As you can see, adding rituximab to Ibrutinib does not clearly improve PFS. As recurrently observed for trials comparing BTK inhibitors versus chemoimmunotherapy, the benefit was not significant for patients with mutated IGHV, and no impact on overall survival was observed, which could result from the crossover design of this study. After this follow-up, all-grade atrial fibrillation and hypertension was 19% and 73%. So the FLAIR study compared rituximab Ibrutinib to FCR in 771 young patients without 17p deletion. Ibrutinib plus rituximab resulted in a superior PFS compared to FCR with a hazard ratio of 0.44. Again here, no clear impact for IGHV mutated patients and no impact on overall survival. 2 observations could explain the lack of overall survival benefit. First, looking at the cause of death, 7 disease-related deaths occurred in the FCR arm and 4 in the Ibrutinib arm. Conversely, 8 cardiac or sudden deaths occurred in the Ibrutinib rituximab arm and 2 in the FCR arm. So in addition, the second line of therapy were very effective and in patients progressing after FCR in this study, so that the 4-year overall survival for FCR in this FLAIR study was 94.5% compared to 84.2% for FCR in the past studies of the same institutions. So other BTK inhibitors than Ibrutinib have been developed and are currently on evaluation with the aim to achieve a high BTK selectivity and minimize off-target effects. Data regarding Zanubrutinib have notably been presented at last ASH meeting. So this is a Sequoias trial that included a cohort 1 here, consisting of an open-label randomized phase 3 study evaluating the efficacy and safety of Zanubrutinib versus BR in treatment-naive patients with CLL. So 479 elderly or FCR ineligible patients without 17p deletion were randomized to Zanubrutinib or BR. At median follow-up of 26.2 months, PFS by independent review committee was significantly prolonged with Zanubrutinib versus BR. Indeed, 2-year PFS was 85% with Zanubrutinib and 69.5% with BR. So treatment benefit for Zanubrutinib was observed across multiple subgroups for age, PNET staging, bulky disease, and 11q deletion status. And treatment benefit was not significant, also here for patients with mutated IgHV. Estimated 2-year overall survival was similar for Zanubrutinib and BR to date in this trial. So regarding toxicity, adverse events of interest included pretty low rate of atrial fibrillation, which was 3.3% of any grade versus 2.6%, and no sudden deaths were recorded and reported in this trial. Treatment discontinuation due to adverse events occurred in 8.3% of patients receiving Zanubrutinib versus 13.7% in those receiving BR. As expected, neutropenia and febrile neutropenia were more frequent in the BR arm. So these data show that BTK inhibitors demonstrated significant improvement in PFS compared to BR. Conversely, no impact on overall survival and no benefit is shown for mutated IgHV patients. And new challenges are emerging. The continuous administration schedule of these drugs raises concern about the cumulative risk of adverse events and the emergence of resistance mutation. With the aim to prevent such consequences of the continuous administration, we are currently conducting the STAIR trial in France, where Acalabrutinib is stopped after an 18-month period in a population of elderly patients with comorbidities. Our hypothesis is that stopping and restarting Acalabrutinib is a safe approach. The primary endpoint in our trial is PFS 1 year after Acalabrutinib discontinuation. Combining BTK with other drugs to set fixed duration regimens clearly represents a promising approach. Dr. Matt Davids from the Dana-Farber Cancer Institute has presented an update of the trial evaluating the combination of Ibrutinib with FCR. So these regimens can provide deep responses with high rate of undetectable MRD and prolonged survival with these 3 optimal rates of 3-year PFS and overall survival above 95% that are in line with the experiences of our group as well as those of the MD Anderson Cancer Center. So now combining BTK inhibitors with the BCL2 inhibitor venetoclax is clearly emerging as a novel fixed duration approach and could clearly become a new standard in a frontline setting. So Ibrutinib and venetoclax have distinct and complementary mechanisms of action. They actually work synergistically since Ibrutinib mobilizes CLL cells from lymph node into the blood and can then enhance the cell killing by priming CLL cells to undergo the mitochondrial apoptosis induced by venetoclax. And this combo can then eliminate distinct CLL cell population. So the Ibrutinib venetoclax combination, the IV combination, has been evaluated in the Captivate phase 2 study. Patients younger than 70 years first received 3 cycles of Ibrutinib, followed by 12 cycles of combined Ibrutinib plus venetoclax. Patients with TP53 alterations were eligible. This study includes 2 cohorts, the fixed duration cohort and the MRD-driven cohort, in which patients with confirmed undetectable MRD were randomized to placebo or continued Ibrutinib. Those with detectable MRD were randomized to continued Ibrutinib or combined Ibrutinib plus venetoclax. CR rate after the 15 cycles was 56%, and a total of 58% of patients achieve undetectable MRD in both bone marrow and blood. So the 2 years post-randomization results were presented at last ASH. So with a median overall follow-up of 38.2 months, we could see that in patients with undetectable MRD, 3-year PFS rates were 95% with placebo and 100% with Ibrutinib. In patients without undetectable MRD, randomized to Ibrutinib versus Ibrutinib plus venetoclax, 3-year PFS rates were 97% with both Ibrutinib and Ibrutinib plus venetoclax. So far, in terms of PFS, there is no clear benefit to date for continuing on therapy after this very effective IV combo of 15 months of duration. But looking at response, in the placebo and Ibrutinib arms post-randomization, modest improvements were observed in complete response rate. And greater improvement in best undetectable MRD and CRi rates were observed with Ibrutinib plus venetoclax than with Ibrutinib post-randomization. During the overall study period across all treated groups, the most frequent grade 3-4 adverse events in this trial were neutropenia, 36%, hypertension, thrombocytopenia, and diarrhea. So the IV combination has also been evaluated in a randomized study, that is the Glaas study, and compared to obinutuzumab chlorambucil, referent regimen in the elderly patients, and the population was patient age over 65 years or with comorbidities defined as high CS score or and creatinine clearance below 70. Patients without TP53 alteration were then randomized to Ibrutinib plus venetoclax or 6 cycles of obinutuzumab chlorambucil. And the primary endpoint here was PFS assessed by IRC. The rate of undetectable MRD using here next generation sequencing and our flow cytometry was a secondary endpoint, and the MRD outcomes have been presented at ASH. So as you can see, 30 months PFS rates was clearly higher for patients in the IV arm, that is 80.5%. As you can see here, versus 35.8% in those treated with obinutuzumab chlorambucil. So IV can induce very deep response, as shown here. Rate of undetectable MRD at 3 months of end of therapy was significantly higher for Ibrutinib plus venetoclax versus chlorambucil plus obinutuzumab in bone marrow, 51.9% versus 17.1%, and in blood, in peripheral blood as well. And interestingly, in the Ibrutinib plus venetoclax cohort, there was a high concordance of MRD level when comparing bone marrow versus peripheral blood. So interestingly, the MRD level remains low over time in the IV arm, since 85% of patients had sustained undetectable MRD from 3 months to 1 year after the end of treatment in the IV arm. And only 29.3% of patients has sustained undetectable MRD in obinutuzumab chlorambucil arm. PFS rates during the first year post-randomization was sustained above 90% with Ibrutinib venetoclax, independent of the MRD status. And in contrast, patients in the chlorambucil plus obinutuzumab arm with detectable MRD in peripheral blood relapsed earlier than those with undetectable MRD. And this complex relation between MRD status and PFS could result from differential nodal evolution. Indeed, as you can see here, lymph node response were better maintained over time with Ibrutinib plus venetoclax compared to chlorambucil plus obinutuzumab, where in patients with detectable MRD, that are the yellow curves here. Regarding toxicity, so this is related to a communication at HIHA, but most common grade 3 or more adverse events were neutropenia, 34.9%, diarrhea, 10%, hypertension, 7.5% for Ibrutinib venetoclax, and for obinutuzumab chlorambucil, neutropenia occurred for 49.5%, thrombocythemia 20%, and pneumonia and tumor lysis syndrome 5.7% each. Interestingly, starting with Ibrutinib only decreases the TLS risk, typically related to venetoclax. And in this study, no TLS were observed. And of note, grade 5 adverse events occurred in 7 patients on IV and 2 patients on obinutuzumab chlorambucil in this trial to date. So our group has conducted a randomized study comparing IV versus the conventional FCR regimen. And the primary endpoint of the trial is the rate of bone marrow MRD below 0.01% at month 27. So IV is maintained until month 15 or month 27 according to the MRD status at month 9. And the MRD results at month 9 have been presented at last ASH. So at the early time point of month 9, rates of MRD below 0.01% was higher in the FCR than those observed in the IVR. And in line with this, using a higher sensitivity MRD approach, responses appears deeper in the FCR arm versus Ibrutinib venetoclax. And there is obviously a need for longer follow-up since we expect that MRD rate should improve over time in the IVR. So even better results than those I've just shown with IV may result from combining 3 drugs, Ibrutinib, venetoclax, and obinutuzumab. And the CLL13 trial has been conducted in fit patients without TP53 alteration with the aim to compare 4 arms: chemoimmunotherapy with either FCR or BR accordingly to age, and the combination of venetoclax rituximab, VR, and the combination of obinutuzumab venetoclax, GV, and the combination of 3 drugs, Ibrutinib, venetoclax, and GA11, so the Guieze regimen. So the co-primary endpoints here were first the rate of undetectable MRD at month 15 and PFS. So the first co-primary endpoint has been presented at last ASH meeting. So here are summarized the main results. So a total of 926 patients with a median age of 61 years were enrolled. The median observation time was around 28 months. And first, the co-primary MRD endpoint was met. Since the rate of undetectable MRD was significantly higher in the JVEN combination compared to chemoimmunotherapy, and which was so 86.5% versus 52%. And the Guieze regimen also showed a superior undetectable MRD of 92.2% compared to chemoimmunotherapy. Of note, the combination of rituximab venetoclax did not result in a superior, in a lower MRD level compared to the combination of FCR or BR. And the most common grade 3-5 adverse events were neutropenia, 55% of all patients, thrombocytopenia, tumor lysis syndrome, infusion-related reaction, febrile neutropenia, and pneumonia. Atrial fibrillation and bleeding events occurred more frequently, of course, in the Guieze regimen, which is the only regimen containing Ibrutinib. So focusing now on patients with TP53 description. Few trials finally focus on these patients, and randomized studies are even more difficult to conduct, but great data have been presented at last ASH. So for this patient, it has been suggested that controlling the disease would benefit more to patients than aiming to cure and eradicate the TP53 subclones, which could ultimately result in a strong selective pressure and subsequent emergence of more aggressive subclones. And supporting this are the results obtained from experiences of Ibrutinib, which provide in the frontline setting, which provide 5-year PFS of around 70%, contrasting with the time-limited obinutuzumab venetoclax regimen, which, while highly efficient in TP53 wild-type patients, only lead to pretty low PFS rates, less than 70% at 3 years. Please note that these are not, however, head-to-head comparison. So this MD Anderson retrospective study have investigated the outcome of patients with TP53 alteration and treated with BTK inhibitor-based regimen. After a median follow-up of 3 years, PFS is significantly better in patients treated with IV compared to BTK inhibitor only. And overall survival were similar and not significantly different across treatment groups. This suggests that very potent combinations such as IV could be the strategy of choice for these patients in the next future. So Sequoia has also evaluated the combination of a BTK inhibitor, the Zanubrutinib, and venetoclax, this cohort 3 here. And this trial also includes this non-randomized cohort evaluating Zanubrutinib venetoclax in patients with treatment-naive and 17p deleted CLL. So to date, 36 patients have been treated. 92% presented TP53 mutations, and more than 80% has undetectable unmutated IGHV, and more than 80% had a complex karyotype. So with a median follow-up that was still short, the overall response rate was really high at 97.2%, including 14% of CR. So looking at toxicity, infection were observed in 23.5% of patients, and neutropenia in 20.6%, mainly of grade 3-4. And 2.9% of patients presented atrial fibrillation in this arm. So in the relapse setting, different options may be proposed depending on prior lines and genomic feature. Indeed, for the patients treated with BTK inhibitor, we know that Ibrutinib resistance results from mutations of the C481 residue of BTK and from PLC gamma 2 mutation as well. These are observed in up to 87% of patients developing resistance to Ibrutinib and are also seen in those relapsing on acalabrutinib. So furthermore, we reported that in patients treated with Ibrutinib, more than half of them developed BTK mutation after 3 years of exposure in the absence of clinical relapse. And such mutations clearly represent a major concern in the setting of refractory and relapsing CLL. So to address this issue, the non-covalent BTK inhibitor are being developed to be able to inhibits both wild-type BTK and C481 mutated BTK. And Ibrutinib, for example, is a highly selective and not covalent BTK inhibitor and has been evaluated in the phase 1/2 BRIN study, enrolling patients with advanced B-cell malignancies, including CLL, who receive at least 2 prior lines of therapy. So among the 260 patients with CLL, the median age was 64 years. All had received a prior BTK inhibitor and 42% a BCL2 inhibitor. BTK mutations were present in 43% of cases and TP53 alterations in 27%. And in this population, the overall response rate was 68%. So with a median follow-up of 9.4 months, median PFS was not reached. On patients previously exposed to both BTK and BCL2 inhibitors, median PFS was 18 months. Importantly, no impact of BTK mutational status was seen on PFS. So the Ibrutinib toxicity seems quite limited also, with 14% of grade 3 to 4 neutropenia, 7% hypertension, and so far only 2% of atrial fibrillation. So another non-covalent BTK inhibitor, the MK-1026, formerly IRQ-531, has been evaluated in 51 patients, mostly exposed to a covalent BTK inhibitor. So the overall response rate was 57.9% at evaluation. The safety was marked by fatigue and constipation, and hypertension occurred in 23% of patients. So as in the frontline setting, the IV combination is very effective in relapsed or refractory patients. And in this HOVON trial, enrolled 225 BTK inhibitor naive patients. So 64% had TP53 alteration. Patients reaching undetectable MRD in blood and bone marrow at cycle 15 of IV were randomized between Ibrutinib maintenance or treatment interruption, and patients with later becoming MRD positive in the stop arm could reinitiate IV. MRD positive patients at cycle 15 remained on Ibrutinib until progression. So even in this relapse setting, IV was very effective. At cycle 15, 36% achieved both blood and bone marrow undetectable MRD, and overall response rate was 86%, and CR/CRi rate was 64%. So the first endpoint was PFS, which was 98% at 1 year post-randomization. Here are the results regarding the MRD outcome in each arm. So patients achieving undetectable MRD remained undetectable after 12 months post-randomization, whatever their randomization arm, 75 and 71%. And no impact of the TP53 status was also not here. So finally, I'm going through some results regarding the COVID vaccine in CLL, since, as you know, patients with CLL have multiple immune defects, and the therapy we use also transiently impairs the immune system as well. So a crucial question in the field is, how is the immune response to COVID vaccine in CLL? So our group has conducted a study collecting data related to humoral response to COVID mRNA vaccines. More than 500 patients were enrolled, 40% were untreated, 26 previously treated, and for 34%, the therapy was ongoing and includes BTK inhibitors, BCL2 inhibitor only, BCL2 inhibitor and anti-CD20 antibodies, or the combination of BTK inhibitor and BCL2 inhibitor. So after 2 doses, only 52% of patients responded. The probability of response was strongly influenced by the treatment status, and 72% of untreated patients respond compared to 60% for those previously treated, and only 22% for those still on therapy. So looking at the ongoing therapy, regimen containing a BTK inhibitor or an anti-CD20 antibody clearly impairs response compared to venetoclax if used as monotherapy. So another group focused on the T-cell response to COVID vaccine by measuring the interferon gamma secretion. So blood samples were collected after a median time of 139 days post-administration and the second dose of vaccine. 46% of patients were on therapy. A response was detected in 32% of patients without any impact of the type of treatment here. While the T-cell response intensity correlated to anti-spike IgG antibody status, only 50% of patients who tested positive for anti-spike IgG antibodies developed positive T-cell response. So here is a summary of the ASH21 key messages to me. First, the continuous administration of BTK inhibitors, Ibrutinib, Ibrutinib, and Zanubrutinib provide better PFS and chemoimmunotherapy in the frontline setting. So fixed duration regimen by Ibrutinib and venetoclax results in frequent and deep responses with prolonged PFS in both relapse and frontline setting, where it has been shown to be superior to obinutuzumab chlorambucil. There is still a need for more data for supporting the potential benefit of maintaining a treatment after this very effective combination. Combining a BTK inhibitor, Ibrutinib or Zanubrutinib, and venetoclax is very effective in patients with T53 alteration. And the advent, finally, of non-covalent BTK inhibitors, such as Pirtobrutinib or MK-1026, is a new hope for patients relapsing after covalent BTK inhibitors. So I would like to thank le CHU Clermont-Ferrand et l'Université Clermont-Auvergne, and also the French CLL group, the PHILO, the French Society of Hematology, and of course, the International Academy for Clinical Hematology for inviting me, and I would also to thank you for watching.
Thank you very much, Professor Guieze, for really very, very beautiful talk. And actually, you managed in roughly 35 minutes to give us a superb summary and well-digested, I would say, overview of the CLL data at ASH 2021. So actually, we have plenty of questions. I'll try to structure them. We may not have time to take all of them, but let me start. I'll try to structure them by order, and I must confess, I'm not a CLL expert, so I do apologize for my ignorance, and in case I say something wrong, please correct me, Romain. First question is, it looks like that the BTK inhibitors are really now the backbone for treatment of CLL. So can you please remind us the differences between the different molecules? I think Ibrutinib was the first to be approved, but now I think in France, in Europe, we have Ibrutinib widely used. At some point, maybe Zanubrutinib will come, and you mentioned also a couple of them that I'm not able to pronounce in your conclusion. So from a chemical point of view and from mechanism of action, what's the difference between these agents?
Yeah, so there is clearly two groups of agents. The first group are the covalent BTK inhibitors. The first one has been Ibrutinib. And Ibrutinib and Zanubrutinib are also non-covalent BTK inhibitors, but that were more selective to BTK compared to Ibrutinib, and some data supported that this better selectivity is related to also a better safety profile, with when comparing, for example, Ibrutinib to Ibrutinib in the setting of relapse. We have seen less atrial fibrillation, less hypertension with Ibrutinib than with Ibrutinib, and there is also some other differences in terms of tolerance. So the other group is the non-covalent BTK inhibitors. And what is very impressive with this new class of inhibitors is that they are not dependent on a specific binding site because they are non-covalent. So they are very active, whatever or not you have this C481 mutation that impairs the binding of covalent BTK inhibitors. So I agree that the names are becoming very difficult to memorize, but this is great because it means that there is a lot of promising molecules coming. But we have so the Pirtobrutinib, and we have also this MK1026, the name being the Nemtabrutinib, and we have also others coming, and that's really something to appreciate.
No, thank you very much. This is really very exciting. Actually, you mentioned, because then I'm trying to link the question. So guys, don't worry if I don't answer your questions in the same order. So I'm trying to put them like in categories. So you mentioned the issue of better safety with the next generation BTK like Ibrutinib. And then you mentioned also they are more selective, so better maybe probably efficacy. So here we have a few questions. Is there still room for using Ibrutinib? Because if you are more effective and you are safer, and you alluded, for instance, to the cardiac toxicities, etc., and we know that the CLL patients, unfortunately, are usually older patients, they do have comorbidities, etc. So what's your feeling here from a practical point of view?
Yeah, so first of all, what is clear is that when we have a head-to-head comparison, and this is great that we have head-to-head comparison within the same therapeutic class, we actually do not see difference in terms of PFS. So, for example, the Elevate RR trial evaluating Ibrutinib versus Ibrutinib in the relapse setting, the PFS were very similar. So we do not clearly expect to gain or lose any efficacy. In terms of toxicity, this is true that we can see less adverse events related to atrial fibrillation and hypertension with Ibrutinib than with Ibrutinib, and there is also such trend for Zanubrutinib. But conversely, we can see that sometimes there is other adverse events that are maybe more frequent. So it's, for example, it seems that there is maybe more headache with Ibrutinib than with Ibrutinib. So
so you mean we need more paracetamol or acetaminophen? No,
yeah, depending of the yeah, when you're in Europe or in US. Now, stuff like this, yeah, and the safety profile is maybe different. And the last point is that we have these very effective strategies combining Ibrutinib with venetoclax and other coming with Ibrutinib, venetoclax, and obinutuzumab. So Ibrutinib is still here because we have this is the first molecule that has been investigated and involved in such combinations that are very effective. So that's some limit I can report on this drug.
Okay, no, this is fine. Thank you very much. Very clear answers, very pragmatic also approach. So I think these BTK inhibitors, which are oral drugs, as you mentioned now, we have really great tolerance with the new generation, but the patient needs to take them continuously. So we have a question here, and we have also actually, and I say hello to all the patient and advocacy groups that are watching, that are there possibilities when you are under BTK inhibitors treatments like Ibrutinib, Ibrutinib, or something else, to have like, you know, I'm going on vacation for 3 months or for 2 months, and I'm going to stop my treatment. Is this something one can consider? Are there any precautions?
So the best option that are being developed so far is to combine Ibrutinib with other drugs and to set fixed duration regimen. So this is what has been done with chemo plus Ibrutinib or with venetoclax plus Ibrutinib. So that's the first approach. And this is exactly the question we are asking in France, where we have this trial evaluating whether or not stopping acalabrutinib in the frontline setting in patients, in elderly patients with comorbidities, is safe at 18 months after starting on acalabrutinib. So this is the STAIR trial, and we are very delighted to have this possibility to answer this very important question that is recurrently asked by patients: could I stop this drug, whether or not safely? So in this trial, we stop the drug and then we will start on drug in case where there is a symptomatic relapse.
So this is something actually, please correct me, similar to what the CML colleagues have been doing, but they do have a marker about molecular remission. So obviously, I guess in CLL, it's about MRD negativity, but that's another story. We have a question here, for instance, from Dr. Salinas, saying when you combine BTK inhibitors and obinutuzumab, actually, or other agent, is there an issue of fitness? What level of fitness, you know, because again, we're talking about usually older patient comorbidities.
Yes, so the more we get in terms of efficacy when combining the drugs, we can see that we are actually reaching a certain level of efficacy. We cannot go maybe very further, very better, and we just can get more adverse events. So that's very important to check that, for example, when you in the CLL 13 trial evaluating 4 arms, chemoimmunotherapy, rituximab venetoclax, obinutuzumab venetoclax, and obinutuzumab ibrutinib venetoclax, we see that we have already very good results with the combination of obinutuzumab venetoclax, and that adding ibrutinib did not completely result clearly to an increase increased response rates compared to so that really needs to be confirmed in terms of survival. And with these 3 drugs combinations, we also have the ibrutinib related adverse effect we do not have with the obinutuzumab venetoclax. So of course, there is really a need to have the final results of this trial, but the first points, the first findings are these ones.
So in summary, while waiting for the results, it doesn't look like always in these older patients that the more is better, because actually you may gain efficacy, but you lose on some toxicity. So we have a good question here. I like this type of question about actually if you have you, Professor Guieze, today, everything available, all kind of BTK inhibitors, all antibodies, even the CAR T cells. We have questions actually about the CAR T cells. And you have a 70-year-old gentleman or lady today with standard risk CLL. And you know, this patient is willing to pay everything, so no reimbursement issue. The ideal would. What do you think? What's your vision about the optimal treatment for these patients?
Yeah, so this is a very good question. So we have now a very large panel of drugs, and that's very important to pick the best ones, but we have also the possibility to adapt the treatment to the specific patients. A lot of parameters are very important, so comorbidities, the age, as you say, and the genomic profile is also very important. For a patient with good risk profile, it's very, I think that the combinations of venetoclax plus obinutuzumab, which is approved now in Europe, is a very good option for patients without 17p deletion, for example. And we have also seen that this combination is really effective in patients with mutated IgHV. So that would be a good option for this. And for a patient with adverse genomic profile, such as 17p deletion, I think that for this patient, the more the better. So if we have the combination of 3 drugs, that would be fantastic. BTK inhibitor, venetoclax, and anti-CD20 antibody. And what is also maybe important here is to have a very long treatment until progression, because when we have started to stop treatment, we see a lot of evolution of the TP53 altered clones coming back and leading to a clinical relapse. So, I mean, 2-3 drugs, but I think that the fixed duration regimen is also frequently asked by patients. We have no very effective fixed duration treatment, so I'm not sure. I mean, go to a monotherapy anti-push.
The continuous treatment versus fixed duration is really a challenge we face in these diseases. I mean, I'm more involved in myeloma, and we have exactly the same problem. The issue we face is that if you are 75-year-old or even 80, and you have a regimen that works, actually you don't want to stop it. Whereas everybody's telling you, oh, we would like to have a fixed duration. So I think the scenario is different if you are older, and then you would say, well, can I win with just one line of therapy compared to someone who is, I don't know, 50-year-old, who is active, want to work. But CLL is a disease of the elderly. So we had a lot of questions actually about the bad risk TP53, but actually I think you have answered this. So let's take another question. I know time is running, so only a couple of questions. Is there still room today for instance, doing FCR, fludarabine, cyclophosphamide, rituximab? Because based on what you're telling me, you know, I do prefer to take like a pill.
Yeah, sure. So that's a very good question. So what some think is that chemoimmunotherapy, the room for chemoimmunotherapy is really, really limited by now. I do think that if you want to do chemoimmunotherapy, for sure, you have to double check the genetic features. If the patient is unmutated, no chemo. If the patient has a 17p deletion, a TP53 mutation, no chemo. If the patient has a SF3B1 mutation, maybe NOTCH1 mutations who have been associated with a significantly poor response to chemoimmunotherapy, I think that for this SH1 mutated and NOTCH1 mutated patients, no chemo the chemo is not the best option. So the room is really becoming tiny, and we have a lot of data that are supporting, as you know, that we have more efficacy with the new drugs in the elderly, and it's also been shown in the young patient. This is what I can say. There is some effort trying to combining chemo with new drugs with very deep response, very high rate of 3-year PFS. So maybe the room for chemo is the association with novel agents, but for sure we know that the new drugs never do worse than chemoimmunotherapy in any case.
Excellent. So definitely, maybe at some point, these old generations need to retire. You know, they have served us very well. But that's another story. Let's take one last question because we still have only 2 minutes. And I mentioned this in my introduction. So we have a lot of questions about CAR T cells in CLL. Although there's no approval of any CAR T cell construct in CLL, and I guess because these patients are living now long and relatively well with taking some oral treatment. And by the way, BTK inhibitors and CAR T cells are being shown to be good partners. So today, assuming we have a CAR T cell construct available and approved, who are the patients you would offer CAR T cell therapy, Romain?
Yeah, so the issue with the CAR T cells in CLL is that, as you know, there is so many immune defects in CLL that we have seen a lot of issues related to the expansion of CAR T cells in CLL. So that's the main obstacle. But that being said, there is some strategies emerging and tested in CLL. But I think that there is two unmet needs in CLL. The first is the Richter transformation. Whatever the new drugs we have, we do not prevent efficiently the emergence of Richter transformation and the risk of Richter transformation. That may be a room for the CAR T cells. And the second possibility is the patients who have been exposed to both BTK inhibitors and BCL2 inhibitors. So we have here the non-covalent BTK inhibitors emerging, and but with not very, with 18 months of PFS, which is pretty good. But I think that for these patients, the CAR T cells is maybe something to good to evaluate.
Excellent. Well, thank you very much again, Professor Guieze. We are really very, very grateful. I do apologize to all those colleagues who posted questions and we didn't have time to tackle them. I'm sure Romain would be more than happy to answer your questions by email if any. It looks like the future of CLL is quite bright. I do remember my medical school, notes, and it was relatively easy when it comes to treatment of CLL. I remember the course, it was supportive care, and then you can use chlorambucil or chloraminofen in France, and that's it. So it was very simple. Now, apparently, it's moving very, very fast, and this is really great news for our patient. So thank you again, Romain, for making this lovely summary of ASH. And also, I need to insist, you alluded to the issue of the COVID-19 in these patients who are highly immunosuppressed. We didn't discuss it during the Q&A, but this is really an important topic, and we have to think to all those patients who suffered and their families from this nasty pandemic, and CLL patients were really very vulnerable. So guys, please continue to stay safe and take your precautions and get vaccinated. So with this, I'd like to thank you all again for being loyal to the different educational activities of the International Academy for Clinical Hematology. Please don't forget that all of these activities are going to be available on demand on the Academy website, clinical-hematology.org. We do have also our channel on YouTube, so please don't hesitate to spread the word. I'd like also to thank all our generous supporters who are really allowing us to perform and to run the IACH activities, which is a non-profit initiative, and especially for these post-ASH webinars. I'd like to thank AstraZeneca for their support, but of course they were not involved in the discussion or the different topics being discussed. So again, thank you all for following, and I hope to see you soon in another IACH activity. Please stay safe and keep well. Bye-bye.
Right, thank you.